and my dear colleagues, senior and juniors, and our today's special guest, Dr. Anita Saxena. It's a pleasure for me to introduce you, Dr. Anita Saxena, Professor of the Department of Cardiology, All Indian Institute of Medical Sciences, New Delhi, India, to all of my colleagues and our students. It's a great pleasure actually because Dr. Anita Saxena, she is one of the pioneer pediatrician of the India who has participated actively in planning various guidelines for management of the congenital heart disease, especially in India and also in our part of the world. She has many publications, like 330 full papers published in various national and international journals. Some of these papers have been referenced in textbooks like Moses and Adams. And she has written 25 chapters in major textbooks covering different aspects of cardiology, especially pediatric cardiology. And her area of expertise is pediatric cardiology, including interventions and valvular heart disease. She is a great teacher and regularly teaching students and training postgraduate students and fellows. She has served as guide and co-guide for over 90 MD and DM students. And she was involved in training and teaching of students. And even now she is involved in these activities from other institutions than that of her own institutes and also other countries. And she was the ex-president of the Asia Pacific Pediatric Cardiac Society. She is a fellow of the American College of Cardiology, president of the National Rheumatic Heart Consortium, past president of the Pediatric Cardiac Society of India, and visiting professor of the University of Manitoba, Canada. Her today's topic is rheumatic fever. So I would like to invite her to start her topics or lecture of rheumatic fever. So dear students, I am welcoming now Professor Anita Saxena to deliver her lecture on rheumatic fever. Thank you, ma'am.
Thank you, Dr. Fatima. Thank you for the invitation. I'm really honored by this invitation, and I'm very happy that you have asked me to talk on rheumatic fever and rheumatic heart disease, something that is very close to my heart. And I always feel that Bangladesh has gone way ahead in controlling this particular disease. And I think that really deserves a lot of applause from international community, that a country like Bangladesh, who is not really considered high income, has been able to reduce the burden of rheumatic fever and rheumatic heart disease. However, there's still cases going on. I'm sure some are still there in your country, and occasionally you must be seeing new cases. So it will be good for the students to learn a little bit more about rheumatic fever and rheumatic heart disease. So just to give a brief introduction, I think we all know that rheumatic fever results from some sort of an immune response to group A, specific types of group A streptococcus. We also like to call them gas. It involves several systems, joints, skin, even brain, but it is the heart that bears the brunt of the disease, and the damage to the heart is permanent, whereas rest all reverse. The joint pain goes away, whether you treat it or not. The skin heals, but it is the heart which bears the brunt of the disease, and that is why we as cardiologists are concerned about rheumatic fever and rheumatic heart disease. It has really gone down remarkably in most of the high-income countries. I think it's related to their style of living and the standards of living and the access to healthcare. But in a number of developing countries, it continues to be a major public health problem. So just briefly about the pathogenesis, we really don't know what is the exact pathogenesis, but there is an interaction between environmental factors, between group A streptococcus of specific types and the susceptible host, which together produces the first episode of acute rheumatic fever. Having said that, everybody who develops group A streptococcal sore throat does not necessarily develop rheumatic fever. Only a small percentage of patients and children go on to develop rheumatic fever. So it has to be a susceptible host. And then there are recurrent episodes of rheumatic fever in these children and young adults, which goes on to damage the heart, producing so-called chronic rheumatic heart disease. Now, why it happens, the pathogenesis is still not understood, whether it is molecular mimicry or it has something to do with T cell mediating the immune response is something that we still don't have an answer. But what we know is that rheumatic fever is a classical example of epidemiological triad where you have the host, the environment, and the agent coming together and producing rheumatic fever in a certain group of children. So these are conventionally the phases of rheumatic fever. It starts with group A beta hemolytic streptococci in the form of throat infection. Rarely it could be skin infection. Goes on to develop rheumatic fever, specifically polyarthritis, and then there is damage to the heart, and then it goes on to develop so-called rheumatic heart disease. But every patient that comes to us with rheumatic heart disease may not have a preceding history of rheumatic fever, such classically as I've shown here. So we should not stop suspecting rheumatic heart disease in children who do not have a history, because about 50% of children and young adults may not give you a history of typical rheumatic fever. Just to give you a brief overview of the burden of the disease, this was published in 2017 that as many as 38 to 41 million cases might be existing in the world with chronic rheumatic heart disease, 3 million with congestive heart failure. And rheumatic heart disease is responsible for as many as 300,000 deaths per year. Remember, these are the patients who are relatively young, under 30, 35 years of age, and therefore this is an important cause of premature death, unlike coronary artery disease, which usually affects older patients. Large number require valve surgery, and we keep on getting new and new cases of rheumatic fever and thereby of rheumatic heart disease every year. The number is very huge. What is important for us to realize is that besides all the chronic cardiac conditions, it is rheumatic fever, which is, and rheumatic heart disease, which are truly preventable conditions, and therefore a lot of emphasis needs to be given to this condition. Also, as I said, it affects children and young adults, and therefore affects the people in their youth of life, and therefore it's a major economic burden on the country in which it is so prevalent. This is just another data from the same article that I was quoting, that as many as 13.17 million clinical cases are existing in India. In fact, if we look at these 5 countries, they would constitute 73% of all RHD cases worldwide. Not only that, even the mortality, 40% of all mortality worldwide due to RHD happens in India, and a significant number in China also. Now, these figures have really remained high for many, many years, and therefore we haven't been able to control it in countries like India and China. And as I said, Bangladesh has really gone ahead and done it very well, and I will show you maybe some data on that. So how do we assess? When we think about managing these cases, we have to really make a full assessment of these children and young adults as to what kind of disease they have. So we must ask for history suggestive of rheumatic fever in the past. It may be there in 50%. We should also look at to the latency from the episode when they had rheumatic fever and now they come back with rheumatic heart disease. What are the specific symptoms? When did they start? The typical symptoms will be breathlessness on exertion, palpitation, and in severe cases, one may get paroxysmal nocturnal dyspnea and orthopnea. We need to see how the disease has progressed over a period of time. And then there are certain specific pointers to specific diagnosis. For example, if there is history of hemoptysis, one can think about mitral stenosis. Palpitation would favor a volume overloading lesion like MR and AR, and even an arrhythmia like atrial fibrillation. If there is chest pain suggestive of angina, or there is history of dizziness or syncope, one has to think in terms of aortic stenosis. And many a times these patients or the parents complain of pulsations in the neck of the child, which can happen with severe tricuspid regurgitation or severe aortic regurgitation. We also must not forget to find out what the precipitating factors have been if the patient has deteriorated recently. So the clinical assessment will include the NYHA class, severity of lesion. In majority of the cases, one can actually assess the severity by clinical examination itself. If there is any evidence of active carditis, and this I will emphasize again because in children, this is particular problem which makes them really worse. And therefore, every child who presents with rheumatic heart disease must be investigated to rule out active rheumatic fever, which may be a recurrence of rheumatic fever. Of course, an X-ray, an ECG, and an echocardiography will ultimately give us the total picture of in a given case. We must determine the severity using these parameters, and then we decide whether we need to start managing these patients with drugs like vasodilators, diuretics, sometimes beta blockers. Patient must be put on secondary prophylaxis, and of course evaluate when do we go and intervene, whether in the form of surgery or in the form of balloon dilatation. So a comprehensive clinical assessment of rheumatic fever and rheumatic heart disease includes affected valves, whether it is mitral, aortic, both, or even tricuspid, their severity, what is the NYHA class, whether there is heart failure or not, what is the rhythm, is it sinus or atrial fibrillation, how much is the pulmonary venous and pulmonary arterial hypertension, what is the ventricular function, are there features of acute rheumatic fever or acute carditis, especially in children, are there any features of infective endocarditis, and what are the precipitating factors? Now, all this data is important when we are deciding about the management of a given patient with rheumatic heart disease, because management will vary depending upon these features. So let's start with first case. This is a 6-year-old girl who presented with recent onset of dyspnea of class 4 for the last 2 weeks only. She did have fever and joint pains about 6 weeks ago. And when we examine, she has features of heart failure in the form of raised JVP and hepatomegaly, and has a murmur of mitral regurgitation at the apex. Now, this is a young girl and has a short history. So she does have severe MR, but very likely she also has acute carditis, acute rheumatic fever, which is making her worse because she has a recent history of rheumatic fever. What should we do next? We must investigate for confirming whether she has carditis or not, because the management will vary. We, of course, do an echocardiography, and then we decide how to manage this girl. So how do we confirm the diagnosis of ARF? It's important to remember that rheumatic fever is a clinical diagnosis where a combination of signs, symptoms, and lab tests are used to make a diagnosis. There is no diagnostic gold standard to say that this patient has rheumatic fever. And because of that, we know that there's something called Jones criteria, which were described by Dr. Duckett Jones in 1944 for the first time. He also divided them into major and minor criteria. Over a period of time, a lot of revisions have happened of these criteria, depending upon the clinical experience of the people or the experts. However, the last revision or the updating has been done in 2015, and I'm sure all of you are aware of this particular revision that has been published in Circulation. Here, for the first time, echocardiography has been incorporated in diagnosing rheumatic fever. Earlier on, it was purely clinical and laboratory diagnosis. The other thing that has happened in 2015 is that there have been 2 sets of criteria that have been introduced. One for the low risk population, like the Western countries where the rheumatic fever has really gone down. And the other one is for moderate and high risk population like India, China, and many countries in this region of the world. Here, the division is based on the ARF incidence of more than 2 per 100,000 or prevalence of rheumatic heart disease in all age group of more than 1 per 100,000. Arthritis, carditis are the most frequent major manifestations. Generally, carditis is seen in younger children, arthritis in older children and adults. Chorea, we know, is less common, and the other major manifestations, so-called erythema marginatum, etc., are much rarer. So this is how the 2015 criteria look. As you can see that they are meant for initial attack as well as for recurrence of acute rheumatic fever. The differences have been that subclinical carditis, which is diagnosed by echocardiography, has been included. Also, they have added monoarthritis and polyarthralgia in the group of arthritis, which was only polyarthritis earlier. Also, monoarthralgia, which was never there, has been put in the place of a minor manifestation or minor criteria. Also, the ESR values and the CR and the fever values are also different for the moderate and high risk population. So with this 2 major or 1 major plus 2 minor criteria for making the diagnosis, one has to have evidence of preceding group A streptococcal infection in the form of either positive throat culture or a positive ASLO or any other anti-streptolysin titer, One can use anti-DNASB, anti-streptozyme, etc. But this is all evidence of a previous or a preceding group-based streptococcal infection. We depend a lot on the ASLO titer. Rising titers are specific to rheumatic fever. In many countries like ours, and I'm sure it must be the same for you, the upper limit of normal is considered as 250 for adults and 333 units in children. So diagnosis of carditis is by auscultation. We must not diagnose carditis if there are no murmurs. So typically you get apical systolic murmur like our 6-year-old girl had. One can also get Kerry-Coombs murmur or an aortic regurgitation murmur during the acute phase. Mitral stenosis murmur is very, very unusual during the acute rheumatic carditis. It is a pancarditis, as is said, because of the biopsies and many other imaging modalities which have shown myocarditis also. But myocardial function is invariably normal in these patients. So if a patient has severe LV dysfunction with mild or moderate mitral regurgitation, we should not think about rheumatic carditis. Rheumatic carditis will have dominant murmurs and less of myocarditis element. Yes, pericarditis in the form of pericardial rub or even minor pericardial effusions are not uncommon during acute rheumatic fever. Remember, pericarditis and heart failure never occur in the absence of valve lesions in rheumatic carditis. So for making a diagnosis of rheumatic carditis, one has to have clinically auscultable murmurs. However, as I said, the new updated criteria have added something called subclinical carditis, and we'll talk about that. So typically echocardiography will show you thickening of the mitral leaflets. There could be nodules on the leaflets as shown over here on the mitral leaflet in about 25%. There could be a little bit of a prolapse. The tip of the mitral leaflet may show a prolapse. There would obviously be mitral regurgitation because that is the commonest lesion seen in as many as 75-80%, and with aortic regurgitation another 20%. So practically 90 to 95% of the patients with acute carditis will have aortic regurgitation, will have mitral regurgitation, and there could be small amount of pericardial effusion. Large pericardial effusions are rare in rheumatic carditis. So how do we diagnose subclinical carditis? There will not be an auscultatory murmur or mitral regurgitation. However, when you do an echo, you do find a little bit of mitral regurgitation happening in some views. And this must be differentiated from so-called physiological MR, which is seen in as many as 40% of young people. How do we differentiate? WHO has given the criteria that color jet should be more than 2 centimeters in length. Jet must be seen in at least 2 planes like you see over here. Peak velocity of the jet should be 3 meters or more, and at least one signal must be holosystolic for mitral regurgitation and holodiastolic for aortic regurgitation. So if you have any of all of these criteria, not any of all of these criteria, then you can say it is a pathological MR and therefore could mean subclinical carditis. Why are we so interested in knowing the severity of carditis, subclinical, mild, moderate, severe? Simply because the severer is the carditis, more is the likelihood of patient or a child developing chronic rheumatic heart disease. So mild carditis is likely to resolve in as many as 70 to 80% of cases, but in severe carditis, almost everybody ends up getting rheumatic heart disease or chronic rheumatic heart disease, and that is why it's an important marker. So what are the challenges in diagnosis? We said there are Jones criteria, which should be able to help us along with the preceding evidence of preceding gas infection. However, these established guidelines should not substitute physicians' experience and common sense. And I'm saying that because in our own experience, a large number of patients really did not fit into the so-called typical Jones criteria. There are several other conditions that can fulfill Jones criteria. And also the diagnosis of recurrence can be quite challenging in those who already have rheumatic heart disease, but they should be suspected if there is worsening of the previous valve lesion, if there is a pericardial rub, if there is a recent onset unexplained heart failure, and of course, if there is a rise in the ASO titer. And we looked at our data, as I was telling you, about 126 children who had acute rheumatic carditis by the clinical criteria made by one of the experienced cardiologists in our department. And as you can see that in as many as 48% of cases, it was a recent worsening of NYHA class, which was responsible or which was an indication that this patient might have developed rheumatic carditis. In fact, a large number of patients did not satisfy the so-called typical Jones criteria in our series. And based on this data, we came up with an evidence-based scoring system to diagnose acute rheumatic carditis in children. And as you can see here, we gave scores to the age, the NYHA class, mitral regurgitation severity, presence of mitral nodules, high ESR of 50 or more, and high ASO of 250 or more. And with this scoring system, we realize that if there is a score of 5 or more, the likelihood of acute rheumatic carditis becomes quite high with a sensitivity of 76% and specificity of 79%. And this we published last year in International Journal of Cardiology. So what I'm trying to say is that rheumatic carditis diagnosis can be pretty challenging, especially in countries where it is very common, endemic, if you only use Jones criteria. Now, how do we manage this girl? We need to eradicate the infecting agent. That means we have to give her penicillin to take care of throat infection with gas. Rest of the treatment is practically symptomatic. Whatever clinical manifestations she has, we have to give treatment for that. If there is heart failure, like this girl has, we have to give diuretics. Sometimes we may be forced to send these patients for valve surgery, although as I said, one would avoid valve surgery during the active phase because surgery may not be very durable. Bed rest and limitation of activity is to be individualized, but generally very strict bed rest for long period is not something which is recommended these days. And of course, like any other patient, secondary prophylaxis must be continued for prevention of recurrence of rheumatic fever. So this is the symptomatic treatment that I was talking about. If the carditis is severe, like in our girl of 6-year-old, we would start her on steroids in the dose of 2 mg per kg per day in 1 or 2 divided doses. And if it is mild carditis, we would only give aspirin. For moderate, you can choose between prednisolone and aspirin. But once the steroids are started, it should be given full dose 3 to 4 weeks and then gradually tapered over the next 6 to 8 weeks, making a total duration of about 12 weeks of steroid therapy for severe carditis. Polyarthritis, if present, needs to be treated typically with aspirin. Very, very useful. It almost immediately alleviates the symptoms of the patients and patient is able to walk from a bedridden position. Chorea, if present, needs to be treated with these drugs as given over here. Treatment is symptomatic and does not alter the course of the disease, but it definitely makes patient feel better. And those who have mild or moderate carditis may not go on to develop significant rheumatic heart disease. However, if the patient is in acute intractable heart failure during the active phase, like in this girl, you can see in this echo, you can see that the anterior leaflet of the mitral valve is practically flail. It is going inside the LA and producing severe mitral regurgitation. Any amount of medical therapy is not going to stabilize her, and this patient really requires surgery. One would try to repair the valve, but repairing during activity is rather difficult, and most of the patients end up having a prosthetic valve, something that you don't want to give them. Therefore, surgery is best avoided and should only be done if there are significant hemodynamic abnormalities producing intractable heart failure. Let's go to another case, 12-year-old boy presenting with dyspnea, class 3 for the last 2 years. So it's relatively long history. There is history of paroxysmal nocturnal dyspnea also, denies any history of rheumatic fever in the past. An examination clearly reveals mid-diastolic murmur of severe mitral stenosis, severe pulmonary arterial hypertension, secondary tricuspid regurgitation, and heart failure. We, of course, being a child, we will always investigate for any acute rheumatic fever, as we should do, but it was all negative. The X-ray shows cardiomegaly with pulmonary venous hypertension, and the ECG you can see shows significant left atrial enlargement and right ventricular hypertrophy, as you can see in lead V1. So this is quite typical of severe mitral stenosis. And obviously the features of mitral stenosis, we all know that because of mitral stenosis, there is dilatation of the left atrium. One can get fibrillation, one can get a thrombus in the left atrium, something that you have to look for in the echo. Dyspnea, hemoptysis, severe pulmonary artery hypertension, right ventricular failure, ascites, and so on. I think functional class is very, very important in mitral stenosis. It is almost always directly proportional to the severity. Or severe mitral stenosis patients may be class 3, class 4 symptomatic and may give history of PND like this patient had. Tachycardia is very detrimental to them because tachycardia produces increase in the transmitral gradient and therefore the dyspnea worsens. So anybody who has mitral stenosis may be stable at rest, but small amount of exercise or any fever can push them into heart failure. Examination again can tell you how severe the mitral stenosis is. A long diastolic murmur, short A to OS gap, thrill, severe pulmonary arterial hypertension, cardiomegaly may or may not be there, and congestive heart failure. They're always indicative of severe mitral stenosis. As I said, the length of the murmur is very, very important. Longer murmur with presystolic accentuation would indicate severe mitral stenosis, and A to OS interval is also important. So this is the echo of the 12-year-old boy. You can see tight mitral stenosis, thickening of the leaflets of the mitral valve, doming of the mitral valve, severe tricuspid regurgitation secondary to pulmonary arterial hypertension, TR velocity jet going up to 70 millimeters of mercury, suggesting severe pulmonary arterial hypertension. So once we diagnose mitral stenosis, whether there is a history of rheumatic fever or not, in a 12-year-old boy, in all probability, it should be considered secondary to rheumatic heart disease because that is the cause in 99% of cases. It is commoner in females compared to males. There may be variable latent period before the symptoms start appearing, but in India and in many countries, the latent period is quite small actually. Dominant symptom is effort intolerance, and severe MS can lead on to PND and orthopnea. So this is an echo showing a thrombus in the left atrial appendage, as you can see here. And LA thrombus, fortunately, is not so common in pediatric age group because most of these patients will be in sinus rhythm. But if the child or a patient who is on follow-up goes into atrial fibrillation, has a huge left atrial dimension, and there is spontaneous echo contrast, it's very likely that this patient will develop left atrial thrombus. And this is an example which was published in 2012 from our center. And as you can see, it is such a tight mitral stenosis. This has been labeled as a smoking mitral valve. And this obviously very likely precursor that the LA thrombus will happen in this particular patient because of so much spontaneous echo contrast. So coming to the word juvenile mitral stenosis. Juvenile mitral stenosis is mitral stenosis seen in very young individuals. And this was a term that was coined in 1963 by my head of the department, erstwhile head of the department, Dr. Sujay Roy. What it indicates is severe MS at an early age. There is rapid progression of stenosis. That means very short latent period from the onset of symptoms to severe stenosis. Thickening of the mitral valve with severe subvalvular deformity but no calcium. Severe pulmonary arterial hypertension, markedly symptomatic patients, almost all in sinus rhythm, and very rarely having thromboembolism. So this is pretty classical, not only of India, but there have been similar reports from many other countries in Africa, and there is a report recently from Ethiopia. Children who are under 12 years of age may be actually worse off because of malignant nature of the disease in developing countries like ours. So how do we manage this particular patient who is in heart failure, has history of paroxysmal nocturnal dyspnea, severe mitral stenosis? Simple, just take them to the lab and go for balloon septostomy. Balloon dilatation of the mitral valve. And this is done typically using Inouye balloon. I'm sure you all are familiar with it and you've been doing it. But what is important is that these patients must not wait. Of course, you can give them diuretics, you can give them beta blockers for medical stabilization, but best is to quickly take them to the lab. Sometimes you have to do it in an emergency because patient is very symptomatic. So this is the third case of 15-year-old boy who was presented with gradually increasing breathlessness again for the last 3 years, did give history of joint pains 5 years ago, claims to be on regular penicillin prophylaxis, and examination here reveals severe mitral regurgitation. He is not in congestive heart failure. Lab parameters are again negative for acute rheumatic fever. ECG shows left atrial abnormality with left ventricular hypertrophy and volume overload. And X-ray you can see is showing cardiomegaly with left atrial enlargement and pulmonary venous hypertension. So chronic mitral regurgitation patients, unlike mitral stenosis, usually remain mildly symptomatic for a long period of time. Palpitation happens to be the dominant symptom because of volume overload. They may have a high volume pulse, so-called mini water hammer. Typical water hammer is seen in aortic regurgitation. Because of cardiomegaly, they have a hyperdynamic precordium, left ventricular apex. Systolic thrill may be there, and there is a loud pansystolic murmur at the apex radiating to the axilla. They may be flow-related third heart sound on an MDM, without mitral stenosis at the apex, but it is the soft west one which will tell you that there is no mitral stenosis. It is a flow murmur. And of course, later on, if we don't read, then they go on to heart failure, but that's much, much later. Cardiomegaly, presence of heart failure, loud P2, third heart sound, and a presence of MDM would always suggest severe mitral regurgitation. So this is the echo of this child. You can see mitral regurgitation happening. Look at the dilated left atrium, dilated left ventricle, and these are the dimensions given over here. As you can see, the ejection fraction is about 57%, which I would say borderline, because for a mitral regurgitation, we want LV function to be super normal, usually above 60%. So anything less than 60% is considered low in these patients. Like mitral valve disease, aortic valve disease also has a relatively long asymptomatic period. Symptoms only come when there is severe disease. But in a rheumatic heart disease, it is almost always associated with mitral valve disease. So you will have an MSAR or MRAR. Isolated aortic stenosis is rare. It is usually the aortic regurgitation which happens with rheumatic heart disease. Commissural fusion is quite the hallmark here. Again, the severity assessment is done by the cardiomegaly, length of the diastolic murmur, and a Hill sign where the upper limb blood pressure and the lower limb systolic pressures are taken. A difference of more than 40 is considered as a finding of severe aortic regurgitation. Now, when do we decide whether to give vasodilators or not for these patients? Definitive data regarding the benefit of long-term vasodilator is really lacking, especially in children. However, they may be used to reduce systolic pressure in patients with aortic regurgitation, and may also be indicated in severe MR, severe AR patients who have dilated left ventricle or ventricular dysfunction. It is not recommended in patients who have mild or moderate MR or AR and normal LV function. There is no data to say that vasodilators will be helpful. In cases with acute MR, maybe because of carditis or infective endocarditis, nitroprusside infusion is very useful, which is a potent vasodilator. However, remember that one must be very carefully, very meticulously monitoring their blood pressure when being on nitroprusside, because it can lead on to hypotension. Other drugs, of course, penicillin goes without saying. Every rheumatic heart disease patient has to have penicillin for secondary prophylaxis. Diuretics for those in heart failure, mostly we use furosemide. Beta blockers actually do not have any clinical benefit in regurgitant lesions, MR and AR. We use them in mitral stenosis to slow their heart rate, but not in MR and AR. And if there is atrial fibrillation, one should go ahead and start them on anticoagulation. Secondary prophylaxis regime is shown here. It is quite a well recognized way to go about it. Benzathine penicillin is a drug of choice. However, if there is allergy, then one can use erythromycin for prophylaxis. But injectable penicillin is the best way. It is to be given every 3 weeks in older children. One tends to use it for 5 or 10 years, depending upon the severity of carditis. However, in severe carditis or in those who've had cardiac surgery, one may have to go lifelong actually, but generally we would stop at 40 years of age or so. There is no data on use of azithromycin, cephalexin, or other antibiotics. So one should continue to use either penicillin or erythromycin and not any other antibiotic. What are the indications of surgery when managing these children? For mitral regurgitation, all symptomatic patients with severe MR should go for surgery. Asymptomatic patients may also be advised surgery if their left ventricle is dilated. And this is the data from Dr. Karapetis published in 2016, or if there is evidence of pulmonary hypertension. Remember, having a low ejection fraction in mitral regurgitation is a bad sign. And in fact, if it is too low, then it may be best not to operate in these patients because the surgical risks are going to be very high. Also, the post-operative recovery is not going to be great. And therefore, these patients are actually not operated. For aortic regurgitation, it is little more liberal. You can see that left ventricular dimensions of even 4 Z-score are okay. You should only operate when the left ventricle is quite dilated, and even having a relatively lower ejection fraction is also fine. However, if patient is requiring surgery for mitral valve and has moderate AR, it is better to go ahead and do both the valve surgeries together. Combine mitral and aortic regurgitation if present, maybe you need to have early surgery. One, of course, try and aim for mitral valve repair in all cases, but in many patients, it may not be repairable and one may end up replacing mitral valve. Aortic regurgitation repair, aortic valve repair is even more difficult, and majority of the time one ends up having aortic valve replacement. Multivalvular involvement, again, not uncommon. It is seen in 15 to 20% of individuals. Commonest combination is MS plus AR. However, and of course, tricuspid regurgitation is mostly secondary to pulmonary artery hypertension. So in the end, I will just show a couple of slides for prevention and control, because I think rheumatic heart disease, rheumatic fever is a is it preventable disease, and even if patient has developed one episode of rheumatic fever, rheumatic heart disease, still secondary prophylaxis is very, very important for them, so that progression of the disease at least can be reduced. So we know primordial and primary prevention. I wouldn't go much into it. Basically, treatment of sore throat or gas sore throat. Don't have a vaccine for rheumatic fever yet. So we treat sore throat with oral penicillin or any other antibiotic, whichever is available, but better to use simple antibiotic like penicillin, because streptococcus is still sensitive to penicillin. So there is no need to go for high-end antibiotic like azithromycin. Once an episode of rheumatic fever or rheumatic heart disease has developed, then what we do is called secondary prevention, where you basically put them on secondary prophylaxis by regular delivery of 3 weekly injections of benzathine penicillin, which will prevent further episodes of rheumatic fever and therefore further damage to the heart, and thereby it may reduce the progression of the disease. In fact, there is some data to say that the disease may actually regress if adequate secondary prophylaxis is given to these patients. Tertiary prevention is actually when the rheumatic heart disease has gone on to a stage of severe valvular disease leading on to heart failure or replacement of the valve. And here, of course, you do balloon valvuloplasty for severe MS, you do valve replacement for mitral regurgitation, aortic regurgitation. But remember, tertiary prevention is too late. We are actually not treating the patient well. We are changing we are doing palliative procedure, changing patient's own valve with a mechanical valve, and we know that there are problems with the mechanical valve also. So I'll end with this slide because it's a very encouraging slide, which I show whenever I talk of rheumatic fever, rheumatic heart disease, that we say that we will wait for our government to work for us to, increase the GDP, to increase the GDP on health, to become very, very developed, have good roads, have good buildings. But no, Bangladesh has shown us that you don't require all that. If there is a will to do something, it can be done. And here, I think this data is rather old, and then it was published again in 2015 by one of the experts from Bangladesh, where it was shown that the percentage or the prevalence of rheumatic fever and rheumatic heart is still low in Bangladesh. And how was it achieved? It was achieved by early diagnosis and treatment of the pharyngitis, which is primary prevention, aggressive primary and secondary prevention strategies, training of health providers, large scale education about rheumatic fever and rheumatic heart disease. In fact, there is an institution on that, community involvement, and active epidemiological surveillance for patients who already have rheumatic heart disease. So this has been achieved here. There are certain examples in French Caribbean islands also where the same thing has happened, that despite no increase in the GDP or despite no increase in the health economics, the trend for rheumatic fever and rheumatic heart disease has gone down dramatically. So I would end by summarizing my talk. It is rheumatic fever, rheumatic heart disease continue to pose huge global burden, especially in low and middle income countries. The complete diagnosis is very much possible in majority of patients at the bedside by a comprehensive clinical assessment and of course by using echocardiography. Further tests are required in all patients, all pediatric patients, to rule out activity, and must be done because activity is a big problem in pediatric age group. All modes of treatment are palliative. We must remember that whatever we may be doing to the valves, whether we are doing surgery or balloon dilation, this is all palliative. Secondary prophylaxis must continue after intervention also. And remember, rheumatic fever, rheumatic heart disease are preventable diseases, as has been shown in high-income countries, and as has been shown in low and middle-income countries, that the incidence and prevalence of rheumatic fever, rheumatic heart disease has been declining in many of them. It is really, I think, is the will that we want this disease to go away. We want this disease to be prevented. That is all that is required, nothing more than that. Thank you very much for your attention.
Thank you, ma'am. Thank you for your outstanding lecture on rheumatic fever and rheumatic heart disease. Actually, I have the experience to work with you in every EPPCS with the rheumatic fever, and I have presented on your request. I have presented our data many a time in EPPCS, and we have seen that our data in Bangladesh is decreasing. I must say, ma'am, that it is some kind of blessings in disguise. What is the blessings and what is disguise? Disguise is that in our country there is indiscriminate use of antibiotics in like shanty areas, in like poor populations. If they have any sore throat or any pain in the throat, they just go to the pharmacy and they ask for medicine. So the pharmacy people over the counter, they can give this medicine. So they give like this penicillin. So they can get supply of this penicillin over the counter, and they eat this medicine and they become cured. Another thing is that among our doctors, it is practiced in many places. I have seen that if they find that ASO titer is more than 200, they actually consider it as rheumatic fever without seeing other major criteria, minor criteria, only ASO titer, which may be due to throat infection. And you have mentioned that all throat infection and all GS are not going to cause rheumatic fever other than those in the predetermined or group of people. But in here in our country, more than 200 is considered as rheumatic fever, and most of the pediatrician, they have a belief that more than 200 needs treatment. So even I have seen many people, they are prescribing monthly penicillin injection for these children, and I have stopped many penicillin from many prescriptions because it is a very painful one, and even every 3 weekly some of the children, they are getting this. So I think some of these eradication and low carb is due to government activities, due to the activities of the National Institute of the Rheumatic Fever Disease, and involvement of the grassroots level workers and others. But some of these are because of this indiscriminate use of antibiotic, and also for considering all ASO titer as the rheumatic fever and treating them as this. So this is one thing, madam. And another thing is that we are now not getting that much of the rheumatic fever. For example, I am involved with a very busy outpatient clinic in Leavitt Cardiac Hospital. In non-COVID time, the number of echocardiography is maximum here. And in my experience, I have not seen that much of the overt rheumatic fever, but there are subclinical. Like we are getting MR, though the mitral valves are not that much thickened, but there is MR which persists throughout the systole. So we take the history, we find that there is history of the throat infection, and then we label them as subclinical rheumatic fever. So ma'am, my question to you is how to actually diagnose this subclinical carditis, if you can elaborate this for our students, because most of the cases now we are getting is subclinical rheumatic carditis.
Right.
Thank you, ma'am.
Right. So thank you, Dr. Fatima, for your question. I want to first differentiate subclinical carditis from subclinical rheumatic heart disease, chronic rheumatic heart disease. So when we say subclinical carditis, then we are dealing with acute carditis. So there may be fever, there may be joint pains, there may be other evidence or other Jones criteria, but there is no murmur. And then you don't know whether this patient has cardiac involvement or not, and you take them for an echocardiography. So clinically, patient has rheumatic fever, but there is no evidence for carditis. And such patients, when they undergo an echo, which is so easily available these days, you find mild mitral regurgitation. Simply, you were not hearing it either because it was mild, or there is tachycardia, there is fever, and we don't have very good auscultatory skills anymore, in younger generations. So those may be the reasons why you were not hearing the murmur. But patient has all the features of rheumatic fever in the form of fever, joint pains, and all that. So that is subclinical carditis, which is now taken as the major criteria equivalent to clinical carditis. But when we are looking in the community in so-called healthy children who are just coming for something else, and then you tend to do their echo for some reason, like we've done our study, which you might have read, we published in the
Yes.
Heart Journal. Then if you are, let's say, screening a population of children or young adults, and you do their echo and you realize that they are looking fine, there is no murmur, but on echocardiography we find mitral regurgitation which is mild. There may be some thickening of the mitral leaflets, and those are basically subclinical RHD or chronic RHD. And of course now we have those WHF criteria which we formulated in 2000, which was published in 2012, where you know how to differentiate normal from pathological mitral regurgitation secondary to RST. So there are criteria for Doppler, and there are criteria for morphology. So if you have thickening of the mitral leaflet or two morphologic criteria with some doming, and you also have mitral regurgitation by Doppler, then this is definite rheumatic heart disease. If only morphological present or only Doppler present, then it is a borderline or a possible rheumatic heart disease. But these are the patients who are clinically healthy, no fever, no joint pains. You just screen them for some reason because they come to you for for ruling out something, or you go into the community and start screening school children or young adults. Then you start getting these are actually subclinical RHD. Now if you have definite RHD by the criteria given by World Heart Federation, then of course you start them on penicillin prophylaxis. You don't have to do any intervention because they're asymptomatic patients. But if you have a borderline case where you're not sure, then you can either adopt a strategy of starting penicillin, with a lot of people in Africa have done it. I generally would like to see them 1 year down the line again and then decide. Of course, in the meantime, if they get joint pains or something, then they require treatment. But if they're asymptomatic, I'll call them back in 1 year. I'll look at their echo, and about 30 to 40% of actually have gone away. They have regressed completely. So these are the patients where I would not do anything. But if there is any progression, or if from the borderline they become definite RHD, then of course I will put them on penicillin prophylaxis. But that is all they need because they are asymptomatic. It just happens to be an echocardiographic diagnosis of rheumatic heart disease. So those are relatively, let us say, healthy people who do not have any symptom, and you just happen to go into the community and do an echo for everybody, and that is how you pick them up.
Thank you. Thank you, ma'am. There is a question from Dr. Khondokar Hussain. He thanked you for your outstanding presentation. His question is, as you have showed, in case of MR, if LVEF is less than 30%, is not operated, then what is the treatment modalities for that child and what is the prognosis?
So I think the reason why we don't want to operate on these children, because we know that not only they'll have a high operative mortality, their recovery of LV function is not likely to happen, because 30% in mitral regurgitation actually may mean 15% or 10%. Mitral regurgitation always, in the presence of MR, you always overestimate the ejection fraction. So it is a common practice, once you operate on mitral regurgitation, their ejection fraction actually goes down. That's usual. So if somebody has a 30% ejection fraction with mitral regurgitation, his actual ejection fraction, if he did not have mitral regurgitation, might have been 10 or 15% only. So these are the patients who don't do well with surgery. They don't do well after surgery. So really their prognosis is bad irrespective of what you do. So what I would do is perhaps just treat them symptomatically or put them in the list for cardiac transplantation and not do mitral valve surgery, because that's not going to be successful in these patients in the immediate as well as in the long run. So best is to keep them on medical therapy and put them in the transplant list.
Thank you, ma'am. There is another question. When there is only MS or MR with no solid history of arthritis or other criteria, then only past history of ASO titer raised and MS or MR in patient. Should we label it as congenital or suspected rheumatic heart disease or subclinical rheumatic fever with carditis? Should we need any antibiotic prophylaxis?
I would say that any patient who has mitral stenosis, a child who is more than 5-6 years of age, has mitral stenosis with MR or without MR, I would treat it as rheumatic. Whether there is history of rheumatic fever in the past or not, even if the ASO titer was not raised, I would treat all patients with mitral stenosis as rheumatic unless I see them below 5 or 6 years of age, or unless they have a history of having a mitral stenosis from the very birth, or from the very beginning. Otherwise, everybody needs to be treated as rheumatic heart disease because that is the commonest. As I said, 99% of mitral stenosis are actually rheumatic. So I would treat them with prophylaxis.
So related to this question, I just want to ask Madam, yeah, so when we will consider a patient with congenital MS, if the age is less than 5 years, or is there any other more criteria?
So I would just add, an echocardiographic finding. So echocardiographic finding of congenital mitral stenosis may be different from the echocardiographic finding of rheumatic mitral stenosis. Age is an important criteria, surely. History of rheumatic fever in the past is important. But if you are not sure whether it is rheumatic or congenital, then looking at the mitral valve sometimes can tell you whether it is congenital or not. Many cases of congenital mitral stenosis are actually because of supramitral ring or core triatriatum. Supramitral ring is so close to the mitral valve that sometimes it is even difficult to differentiate whether it is mitral stenosis or a supramitral ring. So you have to closely look at the mitral valve. The second thing is having a single papillary muscle, that is parachute mitral valve. That is another cause of congenital mitral stenosis. Commissural fusion is a very classic example of rheumatic mitral stenosis. So there are certain criteria on morphology of the mitral valve. If you look at it very carefully, echocardiography, you may be able to differentiate in most cases whether it is congenital or not. But as I said, if I have doubt in a child who is more than 5-6 years of age, I would consider it as rheumatic unless proved otherwise. If the patient has severe disease, then patient is going to go for surgery anyway, and you can look at the valve or the biopsy at that time to decide whether it was rheumatic or not, and then decide whether to continue with prophylaxis or not. But till then, I will continue with prophylaxis.
So, ma'am, about the indication of the PTMC, we know that if in case of adult, if there is calcification, if there is involvement of the subvalvular apparatus, they actually don't do the PTMC. So, in children, what are the indication, ma'am, for the PTMC for our students?
So, in children, severe mitral stenosis is an indication for PTMC. The results of PTMC in children have been published at least in 2 series from our own institution and in 1 series from Nepal that I know of, and some others from Western countries. And it is generally believed that the results of PTMC are pretty comparable to results in adults. Although you may get more subvalvular deformity in children compared to adults, one has to start with a relatively smaller balloon size in them. We generally would start with a balloon which is 2 millimeter less than what is recommended by a patient's height, so that we don't induce mitral regurgitation or any injury to the mitral valve. But PTMC or balloon dilatation is really wonderful for these patients, and all such patients must undergo balloon dilatation. Of course, the indications are severe mitral stenosis, pulmonary arterial hypertension, symptomatic patient, the usual that you have for adults. Now, when do we say severe mitral stenosis in children? It is something that we don't know very well, but generally an area of less than 1 centimeter square is considered severe in children also, which is 1.5 for adults. So if you have a body surface area of 1 or something in a child or less than 1, then 1.5 in adult is severe. Less than 1.5, less than 1 in children should be considered severe. But I wouldn't mind doing balloon in somebody who is 1.1 or 1.2 if there are enough symptoms, or if patient has evidence of pulmonary arterial hypertension.
Related to this, ma'am, balloon, it needs a high diameter sheath, Mullin sheath to introduce. So for the low body weight, like I did one case, 6 years old, body weight was like 13, 14 kg few days ago. So I use pulmonary balloon because balloon, actually, the 22 sheath is not possible for this small child. So
Right.
how do you do in the children if you need a balloon dilatation in the mitral valve?
So Inoue is 14 French actually. And generally we are able to do it in anybody above 15 kilos or so, because you are going in the vein. So I'm not really unduly worried about Inoue. I think the last balloon that we did with the conventional balloon was like 5-6 years ago. We generally don't use the conventional balloon. Most of the time we are able to do with Inoue. But yes, if there is an issue about the access of the venous access in a very small child, one may have to go and do a conventional balloon or even double balloon. We've done in the past double
Yeah,
balloon also. But Inouye is so much easier, so much more comfortable, and we are so
yeah.
comfortable with Inouye that we like to use Inouye as long as we can. But yes, if you have a 10, 12, 13 kg child, you may be forced to use the usual conventional balloon that we use for
Yeah.
other valves.
Ma'am, other question from Abdul Jabbar. He said, how can I differentiate small vegetation of mitral valve producing MR from rheumatic MR during echocardiography?
Okay, so the nodules of rheumatic carditis vis-a-vis nodules of infective endocarditis may be difficult to differentiate, but what we have seen and what we've written also in article is that these nodules do not have a bizarre motion like infective endocarditis. These nodules tend to be multiple, whereas vegetations tend to be usually single or two. These nodules have the same or a little increased echogenicity than the valve, whereas vegetation's echogenicity is pretty different from that of the valve. So in majority of instances, we are able to differentiate these two. But yes, there will be sometimes images which may be difficult to differentiate, and in that case, I would think about diagnosing, doing a lot of investigations to rule out infective endocarditis, because if I think of it as as a nodule, rheumatic nodule, I'm going to start steroids, which are going to be absolutely contraindicated in infective endocarditis. So one has to be very clear that this is not infective endocarditis before starting steroids on them. Of course, doing blood cultures, all those things are fine, but generally these nodules are quite stuck to the valve and they do not show any bizarre motion like the vegetation. So to be honest, I have not really faced this difficulty. In majority of the cases, I'm able to differentiate. Also, we should remember that infective endocarditis is much rarer than activity in pediatric age group. In adults, of course, infective endocarditis is common, but in pediatric age group, more often you will end up having active carditis rather than infective endocarditis. But I would add a word of caution: be very sure that it is not infective endocarditis before labeling it as active carditis, because then you are going to start steroids on these patients.
And ma'am, the infective endocarditis patient, they are more sick than that of the rheumatic fever patient, and they have some other like hemorrhagic spots and other and clubbing. So you will find some other findings also along with the
Absolutely.
vegetation.
Absolutely.
When your patient develop vegetation, by that time he will be very sick.
Yeah. I think
So
the only problem that I face sometimes to differentiate is the flail anterior leaflet. If it is a flail anterior leaflet, then I don't know whether it is a vegetation which is ruptured the cordy, or it is rheumatic carditis. And there sometimes I get into trouble, and then I look for, as you said, other associations like infective endocarditis features or activity features, history of rheumatic fever in the recent past, high SO titer, high ESR, and all that to differentiate. But sometimes flail leaflet can be very tricky to differentiate.
another question from Dr. Nazmul Islam Bhuya. He thanked you for your outstanding presentation, and he is asking a question. As per pathological aspect, Ashov body is diagnostic, though it is not included in the Jones criteria. Are you practicing atrial biopsy in your institute? If so, what is your experience about biopsy? Another question, you practicing IBIG for Sydenham, Korea, and what is your experience with IBIG?
So I'll answer the second question because I have a very short answer for that. We've not been using IVIG even for carditis, because there is one study from New Zealand where they've used IVIG. So we don't use IVIG. It's an extremely expensive drug for us. So we have never used it. I think whatever data is available in that study is pretty equivocal, and therefore I don't find it to be of much use. Korea, I have never used it. So I don't have any experience of using IVIG. Regarding your question about biopsy, we used to do a lot of biopsies when these patients were going for surgery. We would take away the atrial appendages and send them for biopsy and look for Escherichia nodules. But of late, we've actually stopped doing it because we don't really think that it really adds. If we're getting somebody operated during activity, during active phase of carditis, we do take their biopsy and send them for investigations. And of course, if Escherichia bodies come positive or something, we know. But in the chronic rheumatic heart disease patients surgery, which are majority of patients are actually chronic rheumatic heart disease, we are not doing biopsies.
Another question from Lieutenant Colonel Nizamul Hussain. He is asking, is there any terminology like possible or suspected rheumatic fever?
No, rheumatic fever, we don't have any terminology like definite rheumatic fever or possible rheumatic fever. For rheumatic heart disease, we have, which is basically echo criteria, WHO echo criteria. But for rheumatic fever, we don't. But I think in a number of cases, it is actually true that we are not sure if it is rheumatic fever or not, and therefore we say possible. But we have to really investigate and decide this way or the other, whether it is there or it is not there. And that is where I was talking about our study on rheumatic carditis, where Jones criteria were satisfied in a very small percentage. Not small, in about half of the cases of carditis. In rest of the cases of carditis, we could not apply Jones criteria. We still call them carditis because based on our clinical experience, and therefore we treated them with steroids. And recent worsening of their symptoms, of their dyspnea, was a sort of important feature to make the diagnosis of acute carditis in those patients. So if there is a recent worsening of heart failure in a child, one must think about activity or active carditis and of course investigate.
Thank you, ma'am. There is no more question now. If anyone want to say something, we are running short with the time. There is another seminar after 15 minutes. So 1 or 2 minute comments from the panelists who are here. Like I would like to request Dr. Abdul Salam and Dr. Santosh. You have a lot of articles on rheumatic fever. If you want to say anything in 1 to 2 minutes.
Yes, madam. Thank you. I'm Dr. Santosh, working as assistant professor of pediatric cardiology in National Institute of Cardiovascular Disease. Thank you, Anita ma'am, for your nice and excellent presentation on rheumatic fever and rheumatic heart disease. I have done lots of work in rheumatic fever and rheumatic heart disease in Bangladesh. After our liberation in 1971, first paper published by Brigadier Malik sir, and at that time in 1973, the rheumatic heart disease prevalence was 7.5 per thousand. And after that, several studies done, and probably decreasing in trend. You have seen that in your slide. And recently, in 2005, Dr. Jaman found that the rheumatic heart disease prevalence is very low in our country, which is 0.5 per thousand. And I have done recently a work, the paper yet to be published, and I found in 2018, which is 0.79 per thousand prevalence of rheumatic heart disease, and incidence of rheumatic heart disease is 1.6 per thousand. And this paper yet to be published. And so both these studies from the German and myself, both these studies satisfy the criteria of AHA guideline 2015 that our country is now in low risk country. Our country now is a low risk country for the rheumatic heart disease and rheumatic fever. Thank you, ma'am, for your nice presentation.
Thank you. Thank you, Dr. Santosh. Thank you again from my side, because whenever I have presented any paper on rheumatic fever, I took reference from your study and also from Institute of Rheumatic Fever and Rheumatic Heart Disease, where you were working before coming to the pediatric cardiology. Thank you again. And now I would like to request Dr. Abdul Salam to say a few words in short. Dr. Abdul Salam, are you here? Can you unmute yourself, Dr. Salam?
Yeah.
You are muted.
Audible. Thank you, madam.
Yes, now audible, please.
Thank you very much for giving me the opportunity. My internet is a bit unstable, so question such a state-of-art lecture from our one of the most resourceful person in this part. Professor Saxena. I just want to compliment her for her great presence in this webinar. We had a great learning. Thank you, ma'am, and God bless you. Thank you very much.
Thank you, Professor Abdul Salam. So we are now at the end. So if we summarize the whole things, first is the infection in the throat by the group A streptococcus, and Madam has mentioned that there is some immunological reaction in many parts because there is antigenically similar materials in the hearts, joints, and connective tissues. But heart is the most commonly affected place. So from that group A streptococcus infection, there might be acute rheumatic fever, and then after that there may be rheumatic heart disease. So if we can prevent group A streptococcus infection in the at the very beginning when there is sore throat, that is the primary prevention. And if not, then we can go for the secondary prevention. And for those who are with frank rheumatic heart disease, they actually need lifelong prophylaxis. So those who are interested with the rheumatic fever and rheumatic heart disease, they can read all the articles published by Professor Anita Saxena, and also in our country there are many articles, and I would like to request you to read all those articles. Though we have declining trend in our country, but this question will come to your exam. So the students, you must learn these things. You must know what are the new criteria coming, like monoarthralgia, monoarthritis. So you must have to know for your exam purpose at least that you know all these things, because these are the new inclusion as Madam has mentioned. So with this, ma'am, I would like to thank you very much for taking this lecture. This was a very outstanding lecture, and we are looking forward to see you again in our future lecture classes. Thank you, ma'am. Take care of yourself and stay safe, ma'am.
Thank you very much. Thank you, everybody. Have a good evening. Thank you.
Thank you. Thank you all.